background noise in the hallway, mate. Do you want to shut the door?
I do. I'll shut the door.
I've not only shut my door but locked it to stop unwelcome intruders.
Oh, okay. Okay. Then I just knock on it all the time, incessantly.
Yeah.
All right. I'm going to start and admit people from the lobby simultaneously, which will always be a challenge. Welcome, everybody, to the April webinar for the Tropical Australian Academic Health Centre. My name is Ray Thomas. I'm the Research Education Lead for TARC. Today's topic is Health Economics 101. There's a longer title, and Bonnie will introduce that in a moment. Just before we get started, I'd like to begin by acknowledging the traditional custodians of the land on which we meet today. For us here in Townsville, it's the Woolgoorukaba and Bindals people. And I pay my respects to their rich cultures and knowledge and to their elders past, present and emerging. Sorry, I'm admitting people simultaneously. Oh, they keep coming. Cool, well on you. So just for those of you who do not know, the Tropical Australian Academic Health Centre is a collaboration in Northern Queensland amongst the 5 hospital and health services, the North Queensland Primary Health Network, James Cook University and QAIC, the Queensland Aboriginal and Islander Health Council. And we have specific research themes that include service delivery, innovation in health workforce models, non-communicable disease prevention with high prevalence in the region, and infectious diseases. For those of you who don't know us, please feel free to visit our website, which is on this page, because you'll find lots of helpful research, resources, links to things that we're, the events that we're holding, and much more from all of that. Hang on, I think I'm still, no, looks all good. Okay, so just some housekeeping before we get onto Bonnie, who's presenting today. Please mute your microphones. Thank you very much until we have our Q&A at following Bonnie's talk today. It's going to be scheduled after. Feel free to raise your hand if you're too shy to ask questions out loud. But we're a large group, so raising hands would probably be a better option, and then we can call on you after that. But if you can, in the Q&A, it would be really great if we could see your faces. So feel free to turn your camera on if at all possible. Okay, so without further ado, please meet Bonnie Eklund. Bonnie is an all-rounder. Bonnie is currently a PhD student in health economics, and her PhD investigates the efficiency and productivity of public maternity services in Australia. And through her PhD, she'd like to provide insight into the performance of maternity services and inform the design and delivery of efficient, effective and equitable maternity care delivery. So previously, this is where the all-rounder comes in. Previously, Bonnie has worked as a policy and program manager for the Division of Tropical Health and Medicine at James Cook University. And she's also worked with TARC, the Tropical Australian Academic Health Centre. But now, while she's completing her PhD, she is currently the College Operations Manager for the College of Arts, Society and Education at James Cook University. So thank you very much, Bonnie, for having a chat with us today and talking to us about health economics. I'm going to stop sharing my screen so that you can share yours.
Awesome, thanks, Ray. And let me just try and do the rigmarole of making sure I'm sharing the right screens. Just bear with me, everyone.
That's the notes page.
Let me just see.
Yeah, that's your speaker view.
How about that now? Perfect. All right, excellent. So thank you, Ray, for that introduction. And as you flagged, the title of my presentation today is Health Economics 101, longer title being What is it and why is it important? So the presentation, there's basically 2 main areas that I thought it would be useful to cover for people today. The first section is really that what is it, why is it important, and what are some of the key concepts that it would be good to know if you're starting to do a little bit more work in this area. And then the back half of the presentation is really focusing on what are some of the types of economic evaluations that you can take if you want to do your own health economic analysis, and what are some of the steps when you undertake those analyses. So to kick us off though, let me just see why that's not moving through. There we are. Sorry, everyone. So what I wanted to focus on really first was the idea of what is health economics. So if you Google what is health economics, you're going to come up with lots of different definitions. And so I've thrown a couple of these on that slide there that you can see. So broadly speaking, they kind of tend to fall into two main camps. So you have those that go with, I think, what is a very technical definition around defining health economics as the application of economic theories to healthcare. And so you can kind of see those on the left of the slide. And then you've got those that really sort of focus on that health allocation is about the allocation of scarce resources in relationship to health, so to improve health, to promote health, prevention. And look, you can see that both of those camps kind of really still have elements in common, and I've tried to highlight some of those on the slide. So we're usually always talking about scarce or limited resources. We're talking about the distribution or allocation of those resources, and we're doing it in the sense of we're trying to either improve health or prevent negative health outcomes or improve health. So for me, I think the most useful definition is really a simple one, is that health economics aims to inform decision makers so that the choices they make maximise health benefits to the population. And so that's the definition I prefer. And you'll notice that that definition doesn't really include anything about saving money or cost reduction, which is a not uncommon misconception when people talk about health economics, in that it's often thought of that it's just something that you do to save money or to reduce cost, or it's used in very narrow context. So you're trying to say choose between drug A and drug B. So you do, an economic evaluation, and drug A is less costly and least as effective, so you go with drug A. But to me, and certainly the research that I do and the research that my supervisor and our group does, is really much more than that. It's really about improving the level and distribution to improve population health with the resources that we have available. And we'll talk a little bit more later about distribution and that idea of population health. So it's also really about value. So how can we improve a patient's health outcomes relative to the cost of care? So you often find health economics being brought into that space and those conversations around what is low value care and what is high value care. And health economics can really help us to make some choices around where we're putting resources to make sure that we're delivering high value care. So that's the definition of health economics, what it is, but it also kind of implicitly answers that question of why it's important. And it's important really for two big reasons, is that we constantly need to make choices about what we spend money on. And that's at an individual level, a local level, state, national, international. So I pulled out just as an example, the figure on the right there, figure in blue, that's the top 20 programs in the 2023-2024 Australian government budget. And you can see there that obviously the government's made a heap of choices around where they're going to spend their money. So health is obviously there, but so is education, so is defence. And so I've just put it up there because it's a really good example of the choices that get made about where money is spent. And within the healthcare sector, health economics can really help us make choices that make the most of our resources. The other reasons it's important is because we know that demand for healthcare is increasing, and it's for lots of predictable reasons. And there's people here on this call who'd be much more versed in why that demand is increasing than me. But things like aging population, rising rates of chronic disease, we all know that that's increasing the demand for health services. We also know that demand for healthcare can increase for unexpected reasons. So that graph on the right there, the light blue line, it shows the trend amount of healthcare expenditure in Australia. So in 2021, 2022, it's projecting what we would have spent had the COVID-19 pandemic not happened. But obviously the COVID-19 pandemic did happen, and you can see that total health spending really increased way above beyond what we thought it would have on our projected figures. So again, health economics can help us to make choices when we're faced with those kind of scenarios. So we've got increases in healthcare spending, increases in demand. Again, what sort of choices do we need to make sure that we can make the most of our limited resources when there's high demand for healthcare? So hopefully I've tried to convince you or explain to you what health economics is and why it might be important. So I just wanted to then spend maybe 10 minutes looking at what are some of the key concepts that you're going to come across in health economics. And so the first of these is efficiency. So if you do any reading about health economics, if you even just start doing a bit of a random Google, you're going to come across this concept sooner rather than later. And it is something that we kind of implicitly understand anyway. It particularly gets talked about a lot in the health sector, this idea of efficiency, and a lot of the times really common in relation to the US health sector. So on that right-hand side, that figure there is just a figure that I've pulled out, and it's estimates of wasteful spending in US medical care. So by wasteful, they're saying it's the spending or the utilization of resources that aren't going towards delivering a health outcome. So you can see that there's fraud and abuse. Obviously, fraud and abuse is not going towards a health outcome. Also, their administrative waste. So extra administration that doesn't need to happen, that's not important to getting a health outcome, all that's waste. And that's kind of what, at a general level, efficiency is talking about. It's ensuring that we're getting the most out of something with the least amount of waste. So it's bang for buck, sorry. And so in economic terms, we tend to quantify efficiency by looking at the ratio between what you put in to what you get out. So inputs is what you put in. So in health, that's all the things that go into delivering healthcare. So it's your staffing, it's drugs, it's diagnostic tests, it's feeding patients. And we usually capture those resources through costs. And your outputs is what you actually get out when you consume those resources. So that's a health outcome. And you can capture that health outcome in lots of different ways. So morbidity, QALYs, and we'll talk a little bit more about that later. And so that ratio of inputs to outputs is your very basic definition of efficiency. In health economics, there's also some different types of efficiencies with very precise definitions. I won't go into all of them here, but the ones that you'll probably come across the most is technical and allocative efficiency. So technical efficiency is really talking about that minimization of waste that we were speaking about before. And that's where you're trying to produce a given output, so a given health outcome with the least inputs. So really basic example would be you want to lower someone's blood pressure, so you try to treat their hypertension. You might swap out a prescription, like a brand name drug, for a generic drug. Gives you the same health outcome, but that generic drug is cheaper, so you're minimizing the resources. So you're being technically efficient. Allocative efficiency is less about minimizing wastage and more about maximizing your health gains, so your outcomes. So, and again, you'll see kind of allocative efficiency expressed in different ways. One of the ways is, how do we allocate budgets to achieve maximum health gains, so maximize those outputs. Also, they tend to talk about it in terms of how do we ensure that our outputs are matching our pattern of demand and need. So really simple example is that a health service in an area with a younger demographic, it might choose to allocate its budget more towards maternity care or child health services, because that's really where the demand and need is for that community, rather than, say, aged care services. So that's a very blunt kind of example, but it gives you a sense of that. That's what allocative efficiency is looking for. Where can we put our money to maximize our health gains? So the next key concept I wanted to have a chat about was equity. So in the previous slide, we spoke about efficiency, which is really about maximizing your health gains and ensuring that your budget is going to areas of greatest need, but also making sure that you're minimizing the resources to get your maximum output. So equity is kind of the flip side of that coin, and it's really about the distribution of those health gains. So I'm guessing that most people here would probably have seen that picture that's in that kind of bottom right hand corner before, or a variation thereof. And it's basically showing the difference between equality, so just the equal distribution of resources. Each of those three people is getting a box to stand on so they can hopefully see over that fence. And equity, the idea that we actually distribute resources according to need. So again, you can see that, you know, in our first picture, everyone got a box. One person can't even use their box. The other person's not getting much use out of it at all, the person in pink. And our person in red probably didn't even really need the box, to be honest. So our second picture shows when we have an equitable distribution of resources. Guy in red, no box for him, doesn't need it. Girl in pink, 2 boxes, great. And then our person in the blue gets a ramp so that they can use the resource they've given. So that's a really simple example, and equity can be much more complicated, and it is also still a subjective concept. Someone still needs to make a decision about what is an equitable distribution of resources. But it is grounded in those concepts of fairness, justice, and need to kind of help people make those decisions. In a very health economic sense, equity is really concerned about what resources do we need to provide so people can achieve equal health outcomes. So a really relevant example for us in North Queensland is the distribution of our health services. So if you looked at the distribution of health services in North Queensland purely from, I guess, a technical efficiency point of view or an efficiency point of view, it's probably more efficient to fund health services concentrated in a smaller number of larger centres than it is to, the way we do it, to fund health services in a more dispersed set of services to maximise access. So in North Queensland, we do actually choose to go with a more equitable distribution of resources, and we do fund smaller centres in more regional, rural and remote areas. So in health economics, you've obviously got the concept of equity that's important just for purely humanistic reasons, but there is also a link towards efficiency, both technical and allocative efficiency. So if again we go back to that example on the slide, that first slide, even though it's it's an equal distribution of resources, it's actually not very efficient. There's technical inefficiency. So we've consumed 3 units of resources, 3 boxes, but the only person now who can see over the fence, which is the outcome that we want, is our old mate in red, who could pretty much see over the fence in the first place. So that's not really technically efficient. We've used 3 resources to get 1 outcome. Where in that second picture, you can see that we've still used our 3 resources. Okay, so we've got 2 boxes and a ramp, but now we've got an additional outcome. We've now got 2 people who can see over the fence. So in being equitable in our distribution of resources, we are also being technically efficient, and we're being allocatively efficient in that we're making sure that our resources go where they're needed. So the next key concept in health economics is something that we've already touched on already, and that's this idea of scarcity. So I won't really spend much time on this, as I think most of you are well aware of the scarcity that comes with in the health sector, and I've just popped on the slide, some examples of the types of conversations people have about scarcity in the health system. I did just think it was worth mentioning, though, that in health economics terms, there is a really kind of specific definition of scarcity, and it goes a bit beyond that obvious meaning of not enough goods to go around for everyone. And in economic terms, scarcity really means that our income is finite, and given all the goods and services that we would like to consume, our income is insufficient to finance them all. So to sum it up, the idea is really that under no scenario will we ever have enough resources to meet everyone's demand. Our desire to consume is infinite, but our resources are always finite. So when you talk about that in terms of the health sector, it does sort of make you think a little bit differently around constantly those, we always have those calls for more health funding, and it is always usually for a good cause. So you can see there on that slide, Queensland's lagging mental health system needs substantial funding boost. Absolutely, it probably does. I'm not going to argue against that. But from an economic perspective, you do kind of have to have in the back of your mind that there will never be enough resources to meet the demand for healthcare. So consumers, will continue to demand, and we're never really going to have the resources to do that. So at the end of the day, it means that as we've spoken about before, health economics is always about choice. You're always going to have to make a choice about what resources you have and where you can put them. And I just thought that was kind of good to sort of understand that more technical definition of scarcity. So one of the last key concepts I wanted to cover is about choice and opportunity cost. So we've already spoken about choice quite a bit, choice of where we put our healthcare resources, but opportunity cost is really about what happens when we make those choices. And this idea of opportunity cost is really common in health economics and economics, to be honest, as well. So opportunity cost refers to the potential benefit that we give up when we choose one option over another. So it's the cost of that missed alternative. And so I've put together an example on this slide. So it's basically looking at the trade-off between treating inpatients and treating outpatients. And you can see in that first two columns that for every additional tranche of inpatients that we treat, okay, it's actually less outpatients that we can treat. So you can see there that when we're treating no inpatients, so we're only treating outpatients, we're getting, what is that, 50,000 outpatients. But if we then want to bump up the inpatients treated, 50,000, 0 outpatients. And so that final column shows us the opportunity cost of treating those inpatients in terms of the number of outpatients that we can't keep, so number of outpatients forgone. And so opportunity cost is one of those things that is really important in health economics. And also it's something that healthcare managers, if you've ever had to manage a budget for a healthcare service or you're involved in those decision makings, this idea of opportunity cost is something that they're pretty routinely coming up against. They're always making choices about where they put their budget, and they're always having to think about, well, if I put my budget here, what does that mean that I can't do? And it's kind of intuitive. I think we all know that, but you know, that formal definition in health economics is really around opportunity cost. So another key concept that if anyone's been a health service manager would be super familiar with, even if they don't know the formal definition of it, but they would come across it every day, is this idea of marginal cost and marginal benefit. And so marginal cost is the additional expense to produce one more unit of a good or service. So it's not the total cost of production, but it's just that change in cost if we want to produce that one more item or that one more service. So an example, really rough example, is say you have a clinic somewhere and you've got nurses in those clinics that are delivering vaccines. And in a given day, that clinic can deliver 100 vaccines. So you're going to have fixed costs associated with that clinic and also your nurse's salary. So, you know, they have an annual range rate, and that doesn't really change with the number of vaccines that you give out. Okay, the rent for that clinic is the same whether you're giving 100 vaccines or 101. But just say you did want to increase the number of vaccines that you've given from 100 to 101. So you want to give one more vaccine out. The marginal cost is the additional cost of just that one vaccine. So what you actually have to spend just to deliver that one extra vaccine. So it's things like the nurse's time to deliver it, the actual cost of the vaccine, and any other costs that are specifically required for that one thing. So I don't know, if you whack a Band-Aid on it or you give it a lollipop, that's your cost associated with that one additional unit. So that's your concept of marginal cost. Marginal benefit I find to be a little bit trickier, and I do find it really hard to get my head around this. So the example I use is, think of eating a pizza. So you've got a pizza, 8 slices, say. The first slice tastes really great and you're really enjoying it. And so the benefit of that pizza is the enjoyment you get from eating, you know, slices. But if you keep going, first slice, great, enjoying it. Second slice, also great, enjoying it. Third slice, yeah, still enjoying it. By the fourth, fifth, sixth, seventh, eighth slice, you're not really enjoying it too much. You're feeling kind of full. So the benefit that you get from each slice, the enjoyment of eating, it's actually diminishing. And so that's known as diminishing marginal utility. And so a lot of economic decision making is made at that margin. So it's that point where the marginal benefit becomes less than the marginal cost of doing that one extra thing. And that's when decision makers have to make that choice of, well, when we should consider not actually producing any more units. So the example we've got here is an example I think is using colon cancer testing. And so it's the idea that if we do 1 test, we detect this number of cases. If we do 2 tests, we collect X number of cases and the cost. And so you can see that after a certain number of tests, the marginal costs increase quite dramatically. So you could probably say that point between 2 and 3, you have a really dramatic increase in the marginal cost of producing the test and identifying cases, but you're not really detecting a huge amount more of cases. Okay, so you can see that from 1 to 2 tests, you've got you're detecting an additional 5, and then from 3, 4, 5, 6, you're detecting on average less than 1 case. And so if you're a healthcare decision maker and you've got a budget and you've got resources that you need to allocate, you then need to make a decision about, well, when do I stop producing these extra tests to detect more cases? When is it just not worth the cost? And ideally, to make that decision, we'd also probably have a column in there that talks about the marginal benefits, so maybe assigning a cost to that benefit of the additional cases detected. But nevertheless, this is information that people would be presented with pretty routinely. And so it is up to a person, a decision maker, to decide when are we going to cut this off and not do this thing, when the marginal benefit is just less than the cost it's going to take for us to do that. And as I hinted at before, a lot of decisions are really made at that margin, particularly in health. It's wouldn't say always, but it would be rarity when things are a complete either or and you're not looking at things at that margin. So the final economic concept I wanted to talk about is the idea of a market. And look, to be perfectly honest, it's not super relevant if really all you're interested in is conducting an economic evaluation, but the idea of the market really gets talked about a lot in healthcare, particularly in terms of market failure. And I hate to pick on the US again, but in the US, you get a lot of talk around market failure, so health markets failing, and there's been some really quite high profile examples in the media, which I'll talk about in a sec. But essentially, a market is anywhere where suppliers and buyers come together. And in an ideal or sort of theoretical situation, the prices of goods in that market will be determined by supply and demand. So how much a supplier can produce and what a buyer is willing to pay. And so you can kind of see that in operation, every day when you go and do your groceries. So if there's a drought or a flood, which there's been many in Australia, sometimes at the same time, you might have a supply of a particular vegetable which is decreased. So, spinach supplies basically go down, and then you'll immediately see those prices rise in your supermarket. And so a market that's operating in that way, where it's just the interaction between supply and demand determining prices, is called a perfectly competitive market or a free market. So there's no intervention. There's no government coming in and setting prices. It's a free market. And economic theory says that this is an efficient market. So a free market equals efficient. And look, economists put some really very technical definitions of what efficiency means in this context, but really for our purposes, we can just understand it as that the market's working, we're getting the most bang for our buck. It's efficient in the most basic sense. But you'll see on the slide there that a free market can only operate under certain conditions, which I have listed in those dot points. I won't spend too much time going into those. All I wanted to hope, and I hope that you immediately start to notice that, is that when we're starting to look at the healthcare market, you can see that the healthcare market really fails on a lot of those conditions that you need to have a free market or an efficient market. So the bottom two are the ones that really stand out to me. So this idea that there's no restrictions on potential sellers entering the market. Anyone here who is a health professional will know that there's a pretty big barrier to entering the healthcare market, okay? If you want to be a nurse, an OT, or a doctor, a lot of study, a lot of hoops you've got to jump through. It's not like you can just go off and, open up your own, physiotherapy clinic. It's not the same as opening up a bakery, okay? So healthcare markets fail on that kind of immediately. They also really fail on that last dot point where buyers and sellers are well informed about prices. So if you've been in a car accident and you have a head injury, you're probably not going to be really well informed about the different types of costs that you might need to pay for your healthcare, and to be able to make an informed decision, therefore, about where you might get your healthcare from. Okay. In Australia, an ambulance will come and scoop you up, dump you at the nearest public hospital. That at least is free. In America, well, free in Queensland. In America, you might even be incurring a cost even just to be taken somewhere to get healthcare. So because the idea that the healthcare market doesn't always operate as a free market, it's not efficient. Lots of different nations therefore start intervening in that market. So you get government, intervention. So in Australia, we have significant government intervention to set prices within our healthcare market. So obvious example is the Pharmaceutical Benefits Advisory Committee. It advises the government on, hey, these drugs that have come to market, you should go and negotiate a price with the drug providers so that we're able to subsidize that cost so that people are able to access those drugs. And that sort of intervention is also linked to this idea of universal health access, in that, at its most basically, everyone has a right to be able to access free and, affordable and quality healthcare. So because healthcare markets don't always operate in that theoretical free market efficiency zone, health economists spend a lot of time looking at how healthcare markets work and how they can be optimized. And you see those sort of conversations even in Australia around how we fund healthcare. So obviously we've got that split between the federal government largely picks up primary care, state governments are largely responsible for public hospital care. There's a lot of conversations around, is that the best way to allocate resources? Is that the most efficient way for our healthcare market to operate? And so, as I said, it's not really super relevant if you're looking at conducting your own economic evaluation, but it does get a lot of attention, and it is a really big area of interest. So, my PhD supervisor in particular, she does a lot of work around maternity care and how maternity care should be funded. Okay, and she, at times makes the argument that our public hospital care for maternity services, isn't servicing patients the best way that it could. So she looks at alternative funding models that we might want to go down to fund maternity healthcare, and that's all related to this concept of that, the healthcare market is kind of different, doesn't really operate in that theoretical way that other markets do, like the grocery market. Although again, there will be people who will be telling me that the grocery market also is not operating as in a very efficient market. But anyway, you get my point. So yeah, just something that I wanted to be flagged and to be aware of. So the next half of the presentation is I wanted to look at just some of the different types of economic evaluations that you might want to do or that you might see, and some of the really key things that you need to be aware of if you're going to go down that pathway. So front up, an economic evaluation is really just any analysis where you're comparing costs and their consequences. So I've just represented that really simply on that slide. Okay, it's a choice between program A, program B, and you compare the costs and the consequences. So this slide shows some of the most common types of economic evaluations that you'll come across. You'll kind of see that all of them are measuring the costs in monetary units, so dollars, but they do sort of differ in their identification of consequences. And so before I get very too far, I just wanted to point out that bottom type of evaluation, a cost analysis, you can see that it doesn't have any identification or measurement of consequences, so health outcome. And really a cost analysis is just anything where you're sitting down and identifying the costs of any sort of intervention or choice that you want to make, and you're not really considering the consequences. So it's not super useful in that it can't really help you make that informed choice about which program you might want to go ahead with, but it can still be kind of useful, I think, to start incorporating in your own research or your own projects, in that you can just then start to at least frame out some of those costs that might be associated with different interventions that you want to go down. And even at that point, it might, within your given context or your budget, even just an initial cost analysis might, rule something out as being not feasible because we just don't have the budget for that. But in terms of those other three economic evaluations, you can see that cost-benefit analysis, we're measuring both our costs and our consequences in monetary units. Those can be a bit tricky to conduct just because it's often really hard to put a monetary value on the value of health or life, like people do, but it can be a bit tricky. So they're, maybe less common than some of the others. Cost effectiveness and cost utility analysis, we're both measuring and valuing consequences. Difference though is that with cost effectiveness, we're using natural units and its outcomes that are going to be common to both of your choices. So again, sort of the go-to example, if you're looking at whether to implement drug A or drug B to reduce hypertension, say, the consequence, the health outcome that you might be looking for is a reduction in BP. So you would use that natural unit, BP, as your measurement of the health outcome there. In cost utility analysis, what we actually use to measure health outcomes is health years. And that's really your QALYs and DALY measurements, and people would have, come across those before. The advantage of those is that if you've got interventions that might have different effects that aren't necessarily common to both of those alternatives, that's where your QALYs can be really important. And so again, sort of going back to our hypertension example, most people would be aware that Viagra was initially trialed as, I think, as a disease to reduce risk of cardiovascular, maybe something to do with hypertension. Obviously, though, it had an effect that was not present in its alternative choice of a drug. And so using QALYs, you would be able to capture that effect and build that into your decision making. So in the next few slides, I just want to spend a couple of minutes talking about some of the key things to be aware of with each type of economic evaluation. And I won't spend too much time on this, but so cost-benefit analysis, as I've mentioned, tricky to use in practice, hard to put a value on human life and health. If you are going down that route, though, two common indicators that are used is net present value and benefit cost ratio. So net present value, you're just taking the costs of an intervention away from its benefits. Remember, they're both in monetary units. And when the benefit is bigger than the cost, so your NPV is greater than 0, then that's when you can start to consider, okay, maybe I go with that intervention. Similar situation with the benefit cost ratio. You divide your benefits by your costs. That ratio is greater than 1, then you consider implementing that information. You've got some evidence that is, there is a cost benefit to that intervention. A lot of you have probably already seen cost effectiveness analyses. They're pretty common, and that's the one where we're expressing our consequences in natural units. One of the most common indicators you'll see with this is the incremental cost effectiveness ratio, and it basically gives you the additional cost per unit of benefit. And ICEs often get represented in what we call this cost effectiveness plane. So you've got efficacy on your, the x-axis, and you've got costs on the y-axis. And essentially, if your ICA is falling in that bottom right-hand quadrant, it means that it's more effective, less costly than, say, your existing treatment. So we say that the new treatment dominates. And that's a really, you can see that's probably a pretty clear decision. You would probably choose to go with the new treatment. Where things get a bit tricky is maybe that top right-hand quadrant, where your new treatment's more effective, but it's more costly. So then you go, do I go with the new treatment or do I stick with the old? And to help decision making, sometimes people draw, you can see that dotted line through the graph, they'll draw a maximum acceptable ICA, which is really just the maximum cost they're willing to pay for an intervention. So sometimes that can be still subjective, sometimes it's not subjective. You might only have X amount of dollars in your budget, but it can just kind of help you decide when you do have things that are sitting in that quadrant. So cost utility analysis, super common. Again, you've probably seen them before. These are the ones that use the quality adjusted life years or the disability adjusted life years. Main thing I wanted to mention here was just think about the fact that sometimes using those life year measurements doesn't always capture the desired characteristics in an intervention. So if using QALYs, they don't necessarily capture respect or autonomy, but patients do attach value to these. So in maternity care in particular, which is where my PhD focuses on, there's heaps of evidence to say that patients really value respect and autonomy when they're receiving maternity care, but a lot of QALYs will not capture that. And that can make a really big difference then when you're trying to make choices based on these sort of analyses, if they're not capturing the full scope of health outcome that you're looking for. So very quickly, just to finish up on the steps in an economic evaluation. 4 steps: framing the evaluation, identifying, quantifying and valuing your resources and your health outcomes, your consequences, and then presenting that information for decision making. I won't spend too much time on framing the evaluation because I think most of those points are self-evident. The one thing I did really want to draw people's attention to is the perspective. So the perspective from which you decide to do an economic evaluation, whether that's from society as a whole, from the federal government, from the state government, from the health system, from the health service, from the individual, it's really important and can change the type of costs and consequences that you look at. So, for instance, if you're in Australia and you want to do an economic evaluation from the perspective of a patient accessing public hospital care, you'll basically only be looking at the out-of-pocket costs that individual will pay, because from their perspective, all the other costs are covered by the government. But if you're going to do that same evaluation from the perspective of the health service, obviously you're going to get very different results, because obviously that public hospital is covering a huge portion of costs. So again, this goes to our second step. Once we've framed our evaluation, we need to then identify our resources. The only thing I wanted to flag here, I think the first couple of dot points pretty straightforward, is this idea of average versus marginal cost. So as we've spoken about before, often we're more interested in the marginal cost of production. So what's the cost of producing one extra unit and what's the benefit, rather than looking at average costs. Level of precision can also be really important. So in my own research, I essentially calculate costs from the Australian DRGs, but that isn't really necessarily reflective of the actual cost of an individual that's moving their way through the health system. So if you want sort of that level, that's kind of known as microcosting, very manual data collection. The other one that is worth, and I've only got a few more minutes, I can see Ray probably freaking out that I'm going to go way too over. But I did want to mention, because you will come across it, and it is important to be aware of it, is this idea of time preference and discounting. So if you're going to do an economic evaluation and you're looking at costs or consequences that might occur in, say, 2, 3, 4, 5, 10, 15 years' time, there's this idea that, I find this one a little bit weird myself, but it's the idea that basically people place less value on future costs and consequences than they do present costs. So for example, I'm going to go on holiday in August. I've got a holiday booked. I'm doing the Guard, going through the middle of Australia. Awesome. If someone came to me and said, would you pay $50 to guarantee that in August this year you'll be healthy for the entire year so that you can go on your train trip, I'd be like, sweet, bargain. Yeah, sign me up. Here's my $50. If someone came to me and said, in 10 years' time, would you pay $50 now to guarantee that you are healthy for the month of August in, 2034? I'm not that interested in that. So people value things in the future less. And so when you're doing an economic evaluation, essentially you then have to discount things that occur in the future. And there's national and international guidelines around how you can do that. So the UK discounts at about 3%, Australia, we're up around 5%. So just something to be aware of. Again, the consequences, as I said before, lots of different measures. Most of those are straightforward. I don't want to spend too much time on them. Just wanted to flag that you do want to have a carefully look at how your QALYs and DALYs have been created. So you might have QALYs that are based on not so much your specific state of disease, but on kind of a general health state. So you just kind of be careful around your choice of those and how they've been derived. Last thing I want to talk about in the steps of an economic evaluation is this idea of the final step when you're presenting your evidence. And it's just this idea that when you present an economic evaluation, you can do something called a sensitivity analysis, which it provides a measure of how confident you are in the results of your evaluation. And it really just involves varying some of the key assumptions in your evaluation and getting an idea of how that impacts the result. And if you ever have to do one of these, there are methods available in your standard SAS packages, so R, SAS Data, to do that kind of sensitivity analysis. Final 2 things I wanted to mention is that we've spoken about steps in conducting an economic evaluation, but you might be someone who gets economic evaluation. So someone gives you an evaluation and you need to interpret it to make a decision, or you just, it's part of, if you're looking at going down a certain pathway, you might be looking at other economic evaluations that have been done. Really useful thing whenever you're presented with an economic evaluation is to check out something called the Drummond checklist. And so that's really a framework for assessing the results of any economic evaluation. So it was first published way back in 1985, but it's really stood the test of time. It's been used today. And it's 10 questions that you can ask yourself about any economic evaluation. So I've dumped those 10 questions on that slide there. If you go to that reference, the updated version, some of those questions have kind of sub questions that kind of help, better delineate what it actually is that you're looking for. But it is really super helpful to help you evaluate, an economic evaluation if that's something you ever need to do. And final slide is, I thought it might just be useful for people if you're interested in health economics and you might want to get some more information, I highly recommend the book that's the pictures there on the right, Introduction to Health Economics. I've gotten a lot of the text, a lot of the information for this presentation from that slide. It's really great, really simple, really straightforward. It's got some activities that you can work through. So yeah, if you are interested, I would highly recommend that as a resource. There's also some online resources available because TARC is one of the nationally recognised research translation centres. So the South Australian Research Translation Centre did a spotlight series on health economics. They've got some cool webinars there. There's also something called the RET program, Health Economics, where people who are partners of the National Alliance ARA of Research Translation Centres, they kind of get subsidised short courses in health economics. There's also some other courses there. So consumer and community engagement, there's some things on clinical trial, so I'd suggest checking that out. And New South Wales Health also has some good resources around economic evaluations, so how to conduct them, the different types, how you might consider incorporating them into your own research. So yeah, worth checking out if you are interested. And that is essentially it from me. So I will stop talking for a moment and I guess, yeah, open it up for discussion and or questions.
Thank you very much. That was the first. I'll go first. That was the first economic, health economic talk I've been to, and I want to learn more. So you did a good job. Thank you.
Box ticked.
I see a question in the chat, and I'll get to that in a minute. Does anybody online would they like to ask a question first? Any cameras, any mics, any hands? Okay, the question in the chat, people having to leave. The question in the chat is, how do you measure QALYs and DALYs? Okay,
so I'm by no means an expert, and I will put it out there that I find it confusing. So this is a very basic understanding from me, is that, as I said, there's really two ways that you can measure QALYs and DALYs. The first is direct measurement. So for a specific, and look, if someone knows the answer more than me, and please feel to jump in. First one is direct methods, where for a specific disease state, there's basically methods where you go out and you survey people. So there's time trade-off, standard gamble, visual analog scale, and it's basically you ask people a series of questions around kind of what, for a specific disease, what health state they prefer. Would you rather, and so it's, would you rather live 5 years in imperfect health, or die early, to be crude. I said not my real thing. And then there's the more indirect off-the-shelf measures where it's more general around health state. So I think the Euroqual 5 dimensions or something is used quite commonly. And so that asks questions around like, I can't remember off the top of my head, but like, mobility, daily tasks, anxiety, depression. And again, it's just asking those questions around, what would people prefer in terms of health state versus, death. Again, to be honest, that's probably a terrible explanation, but in a nutshell, that's kind of my understanding. And so you need to choose an appropriate one if you're doing an economic evaluation.
And I think you put the resources that you put up, I think, will be really, really helpful for people who are interested in learning more about this. Anybody from the floor? Because I have one if you don't. I have several. Okay. So that Drummond checklist that you put up, is that like a critical appraisal for a health economics sort of evaluation? Is that the kind of thing that it would be looking at?
Yeah, very much so. So I probably didn't set it up there, but it's sort of it has a lot of questions in common with the critical appraisal. So is a well-defined question being asked? Have you adequately described the competing alternatives? The evidence that's been of the effectiveness of the program that's been offered. Yeah, so it's pretty. And if you're familiar with that, critical appraisal checklist, there'll be heaps of overlap with that Drummond checklist. It just kind of narrows it down to be more, I guess, economics-y focused.
Yeah, that's excellent. Thank you. I'll keep going because people are listening. Will the slides be for this presentation be provided? The webinar has been recorded, as are all the TARC webinars, and that will be up on the TARC YouTube channel. I would say by Tuesday, if you give me a little time to do that. So if you want to check out the TARC YouTube channel using the website www.tarc.org, you will find it up there. Anybody else have a question? I've got another on that cost effectiveness plane quadrant that you showed us, right? You had that, and you had in the top right hand quadrant, you had where you needed to make some certain. Can you share that slide again just for a minute for us? There, yeah. So the maximum acceptable ISA that you have in there, to determine what that might be, would that be a place, and heaven forbid I'm asking a health economist to do more, but if you've done a cost effectiveness analysis and you're on that plane, you're unclear where that cutoff might be, would that be a place where cost benefit analysis might provide you, even though we know, as you said, there are lots of difficulties in doing the cost of benefit analysis? Is that a space that might help you sort of make a decision in that top right quadrant?
Yeah, sure. And look, I think definitely you could use it in that way. And I think a lot of the time, yeah, it just becomes very subjective. So I think, yes, if you can pull in, anything to sort of help with that analysis, you can. I mean, look, the incremental cost ratio is already taking into account, those incremental benefits. But yeah, I guess it just goes back to that idea that it is about choices, and that even though you can sort of, there's areas where it's very clear cut, but then there's others where it's not, and it does come down to that, subjectivity. Yeah.
No,
And also maybe, I guess that's where, some of those concepts that I spoke about earlier also too about equity might come into it as well. So if you've got a new treatment that's more effective, but it's more costly, but maybe it's being directed more towards an equity group. So, a group, a population of people that it's really important where you want to improve those health outcomes. That might be something that you take into account when you're doing that kind of subjective analysis.
Fair enough. Look, that's been fantastic. Thank you very, very much for that. You're getting lots of congratulations on the chat. Not sure if you can see them. That was great, Bonnie. Most interesting. Well done, says Mary. Great from Gail. People are bumping out to other meetings. So the webinar will be available on the TARC YouTube channel, which actually Bonnie put up. So Bonnie was the one who actually did that. I'm just following Bonnie's rules about how to do that. So that's where that sits. But the other thing, just for those of you in Queensland Health, the Office of Research Innovation say that they're putting on a health economist. So we all know that health economic evaluations are more and more important, and rightly so. So I do know that they're putting on a health economist, but the person I think is going to help everybody in the state. So I'd start making your applications for support now if you need them, because it'll be a very, very long queue. And thank you very much, Bonnie. That was really, really fantastic. And thank you all for attending. And let us know if you have any burning needs to have any other sort of information provision and skill sessions. Thanks heaps for that. See you, everybody. Thanks,
Awesome.
Bonnie.
Thanks, everyone. Ta. Bye.